Hi guys, welcome to another lecture on medicinal chemistry. And today we're going to be talking about anti-allergy agents. So, what is an allergy? Well, it represents a sensitivity to a specific substance called an allergen that is contacted through the skin, inhaled into the lungs, or injected. So if you look at this image here that's titled Types of Allergens, we see where we could have a variety of exposure here from jewelry, latex, plants, milk, bee sting, dust, pollen, etc. Right? So either by the skin, injection, or inhalation. So, having looked at that, I'm sure that you must have experienced some type of allergic reaction, or you know somebody who have experienced some type of an allergic reaction. If that's the case, that suggests that it's quite prevalent, and this is how prevalent it is. Approximately 30 to 40% of the world's population suffers from allergic diseases. Allergic rhinitis affects 400 million people annually, and food allergies affect 200 to 250 million people. So at least 3 out of 4 people with asthma also have allergic rhinitis. So essentially, you're exposed to the variety of allergens that I mentioned earlier, and then you experience some type of an allergic response, such as watery eyes, runny nose, or an itchy throat. According to Gel and Coombs, there are 4 types of allergic reactions. So, type 1, which is an immunoglobulin E mediated one, is the mechanism is immunoglobulin E binds to mast cells with inflammatory mediators released. The clinical manifestations are anaphylaxis, this is hives, and angioedema. The timing of reaction is immediate, that is minutes to hours. In comparison to, for example, type 4, which is delayed cell mediated, mechanism is T, lymphocytes, etc. And the clinical manifestations contact dermatitis, and the timing is 48 to 72 hours, right? So we have a variety of types, a variety of mechanisms, and a variety of manifestations, and also a variety of timing of reaction. So you may be exposed to skin tests for a particular diagnosis of allergy. Well, if you relax your hair, or have to take anything, rub anything on your skin, you may have been directed to take a little bit of it and introduce it to your skin to see whether or not you are allergic to it. Well, this is called a skin test. And in the case of the image here, several allergens are introduced to the skin. The test is positive if the skin shows a reaction. All right, so directions of therapy for hypersensitivity reactions of immediate type. Well, our focus, as I mentioned at the onset, is anti-allergic drugs, right? But we're going to also mention the other 2 categories. So, under anti-allergic drugs, A, drugs which stabilize membranes of mast cells and basophils and slow down releasing mediators of hypersensitivity reaction. And B, which is mainly our focus, antihistamine drugs, which block receptors with which histamine binds in the tissues, and we're mentioning the other two. Drugs which decrease damage of tissues, which are glucocorticosteroids, and of course drugs of symptomatic treatment, adrenaline, etc. So this leads us to our first question, which is, contact dermatitis falls under which category of allergic reactions? And if you answered type 4, then you are indeed correct. So the term antihistamine, which is the title of this slide, historically has referred to drugs that antagonize the actions of histamine at H1 receptors rather than H2 receptors. So the development of antihistamine drugs began more than 5 decades ago with the discovery of piperoxan, and we have the structure of piperoxan here. Was able to protect animals from the bronchial spasm induced by histamine. So once those observations were made, what followed was a synthesis of a number of N-phenyl ethylene diamines inspired by piperoxan, with the hope that they will have increased activity or that they will be superior to piperoxan, right? So it's very important to know where we started from, what inspired, the line of drugs that we have today. Well, it started off with piperoxan. So further structure activity relationship studies in the series, based largely on the principles of isosterism and functional group modification, led to the introduction in the 1940s to the 1970s of a variety of H1 antagonists containing the diaryl alkyl amine framework. So at this level, at your level, you are familiar with functional group modification. You may be less familiar with isosterism, right? And it was a term coined by Longmuir in 1919, which means compounds or groups of atoms having the same number of atoms and electrons. So for example, we have 2 pairs of compounds there with the same number, and you can do the calculations yourself. But clearly we can see that they have the same number of atoms, 2 in one case, 3 in the other, and then we can add up the number of electrons to see if they are indeed the same. And if they are the same, then they are related by isosterism. And what that means is that if we have a particular compound, we can replace one of these groups with another with the hope that it will have similar activity. So classical bioisosterism actually was originally formulated by James Moore and refined by Longmuir as a response to the observation that different atoms with the same valence electron structure had similar biological properties. So what you will find though in medicinal chemistry is that you will see less of isosterism and more of functional group more of that term, functional group modification. But I mean, clearly they are related. All right, so antihistamine drugs have the structure seen here. Well, the structure of the nucleus of these antihistamine drugs, right? So you will perhaps see 2 aryl groups and bonded to nitrogen is commonly seen in these antihistamine drugs, and some alkyl group attached to the nitrogen. But as you'll see later on, the structure is not set like this for all antihistamine drugs, but they have some similarities in structure. All right, so for allergy, what is an indication is histamine production, right? So histamine is actually an endogenous bioactive amine, and you should know what all of those words mean, which is biosynthesized, stored, and released in mast cells, which are abundant in the skin, GI, and respiratory tract. Basophils as well, it's synthesized there in the blood, and it's a neurotransmitter in the CNS and the PNS. In terms of the physiological actions, it's a primary stimulant for gastric acid and pepsin secretion. And as I mentioned already, it is a neurotransmitter in both the PNS and the CNS. For the pathophysiological action, it's a mediator of immediate hypersensitivity reactions and acute inflammatory responses. So what is the structure of histamine? Well, it's composed of an imidazole heterocycle, which is circled in pink, and the ethylamine side chain, right? So that is the structure of histamine. In terms of the biosynthesis of histamine, and histamine can be called beta imidazolyl ethylamine, is synthesized from L-histidine by histidine decarboxylase, as we see here in the equation. And the enzyme, it's an enzyme that is expressed in many mammalian tissues and others, mast cells, basophils, CNS, etc. Right? So essentially, L-histidine is decarboxylated, because as we see here, the only difference between L-histidine and histamine is the fact that we have a carboxylic acid here, and the carboxylic acid has been replaced by a hydrogen for histamine, right? And so the enzyme L-histidine decarboxylase, as the name suggests, decarboxylated L-histidine to form histamine. All right, so another question is, what's the relationship between the following groups of compounds? That is, what's the relationship between hydrogen and these, hydroxyl and these, methylene and these, benzene and these, or phenyl and these? Well, if you said bioisosteres, then you are indeed correct, and I cannot call that word for the life of me. All right, so that is the relationship between them. So as you can see, it's not a strict and rigid term, as Longmore had said, with the same amount of atoms and same number of electrons. We can see here that we have 2 atoms here and we have 3 here. So it's not a rigid term, but it's essentially should be similar amount of valence electrons or similar electrons, number of electrons, I should say. All right, so for the metabolism of histamine, we can see that it has 2 parts and 2 end products. So metabolism of histamine takes by the enzymatic inactivation. So here, these are the 2 enzymes involved: histamine N-methyltransferase here, and diamine oxidase. So clearly it is involved in some oxidation, and clearly this is involved in some methylation. Histamine is metabolized and as these two final products, so N-methyl imidazole acetic acid here and imidazole acetic acid riboside here. Both are excreted through the urine. That is, the two metabolites are excreted through the urine. So for histamine, this is the structure of histamine as we have seen. So it is methylated here, and that is catalyzed by histamine N-methyl transferase, HMT, and essentially, as we can see, the hydrogen here is replaced by methyl, and then we have oxidation on this final step with diamine oxidase playing a key role there to the oxidation of this carbon to carboxylic acid. And in the first step on this side of the chain, we have oxidation occurring to the aldehyde and further oxidation, and then finally the addition of the riboside. All right, so the key points here is that the metabolism of histamine doesn't follow one route, it follows two routes, and two different metabolites are synthesized, and both are excreted through the urine. All right, so for the allergy histamine receptors, our focus will be on H1 receptor, and that's because it results when stimulated into allergic conditions and sleep disorders, and to a lesser extent H2 receptors, which results in gastric acid secretion, and to a lesser extent H3 and H4 receptors. So what are the effects of histamine? Well, as we can see on this slide, it has several actions on several different target on different organs, right? So these receptors are clearly on these different organs, and they have a different impact when stimulated by histamine. So for example, vascular H1 vasodilation mediated by NO1-PG, heart, increased AV conduction for the lung, bronchoconstriction for the GI tract, H2 acid, fluid, pepsin secretion, and for the cutaneous nerve endings, H1 pain and itching, right? So this is a common one. So essentially, the effect of histamine varies depending on where the receptor is located, as we can see here. And just to summarize, what was on that previous slide in terms of the mechanism of action of histamine, we're saying that for the H1 receptors, it causes an increase in the calcium ions, which therefore causes a smooth muscle contraction, increase capillary permeability, vasodilation, sensory nerve ending pain, and itching. And for the other two receptors, there's an increase or a decrease in cyclic adenosine monophosphate, and it has different effects, whether it be increasing gastric acid secretion or decreasing histamine release. All right, so the symptoms range from mild allergic symptoms to anaphylactic shock, as we saw, based on the different types that we saw earlier. So mild cutaneous, that's the itching that we saw, and hives is hives. moderate skin reactions, severe hypertension, bronchospasm, etc. that we saw. All right, so our next question is, what's the difference between N-methyl imidazole acetic acid and imidazole acetic acid riboside? So without even looking on the structure, we can look at the words themselves and we can look at what the differences are. So for both of them, we have imidazole acetic acid, and the only difference is that we have riboside in one and methyl on the other. Of course, you know, it'd be nice to look at the structures again, right? So one has a methyl, one has riboside, right? And that is the difference between both. So that's the answer, methyl versus the riboside. All right, so for allergy drugs targeting histamine, right? As I said, we're focusing mostly on H1 receptor antagonists and H1 receptor blockers, same thing. They are anti-allergic drugs, and to a lesser extent, we'll be looking at H2 receptor antagonists, H2 histamine blockers. I mean, we have mentioned them, but in terms of drugs, our focus, as I said, H1 receptor antagonists. So these drugs, the H2 receptor antagonists, they decrease secretion of HCl, used for treatment of stomach ulcer, and of course you have your mast cell stabilizers. So the mechanism of action of antihistamine drugs, well, as the name suggests, and as we have been mentioning, they block histamine H1 receptors, resulting in reducing or eliminating the effects of histamine. So we're talking about spasm of the bronchial tubes, intestine, uterus, lower blood pressure, increased vascular permeability, itching, swelling, redness, right? So that's essentially what it does. Plain and simple, blocking the particular receptor, reducing the effects of histamine. So what we have an image here of a mast cell, in which, as we saw in the biosynthesis of histamine, that it starts off with L-histidine and is converted to histamine, which is released, and naturally once it is released, it creates an allergic response. When it is blocked by these antihistamine, it prevents the H1 receptors from functioning as we see up here. So let's now look at some first generation drugs which are sedating. So we're changing our focus now and looking at drugs. H1 antagonists, which are also antihistamine drugs, first generation drugs which are sedating. So we have a list of them here. I'm not going to call all of them, but ethylene diamines, which is the first set of antihistamines, are now obsolete, and you have some ethanol amines, some alkyl amines, and piperazines, which all fall under the category of first generation drugs which are sedating. In terms of the structure of these first generation drugs, they are similar in the sense that they all have nitrogen. And for these, we have our diaryl functionality and our little chain here, and our nitrogen and our alkyl group, in this case methyl or other alkyl groups, attached to it. And then we have some that look a little bit different, right? But essentially all of them have an aromatic group, all of them have nitrogens connected in some type of way. For the pharmacological characterization of antihistamine drugs of the first generation, they have a variety of side effects manifested because of the peripheral anti-muscarinic effects, They block M receptors, causing dry mouth, blurred vision, constipation, etc. Anti-serotonin, they have anti-serotonin activity, causing an increase in appetite and therefore increase in body weight. They potentiate CNS depressants, that's opioids, sedatives, general anesthetics, etc. They are injectable forms of release used for treatment of acute allergic conditions. Continuing on these first generation antihistamines, the effect occurs within 15 to 20 minutes after administration, so not bad. However, they penetrate through blood-brain barrier. Clearly, they must be lipophilic if they are to cross that barrier, and block hydrogen 1 receptors of CNS, and as a result cause sedation and reduce coordination of attention. So another negative is that they have short duration of action as prescribed 3 to 4 times per day. And another one is that prolonged use develops tachyphylaxis, which is reduced therapeutic efficiency. Therefore, you have to replace one drug for another in this group every 7 to 10 days. That's not good. All right, so what are the indications for use of these first generation drugs? Well, antiphylactic reactions, anti-allergies, allergic rhinitis, for example, contact dermatitis, sedative, sleep aid, prevention of motion sickness, pre-medication, and for potentiation of CNS depressants. All right, some side effects of these H1 histamine receptor blockers of first generation. As we mentioned, depression of the CNS, so that's several disorders there related to the central nervous system. Disturbance of the GI functioning, several side effects there. We mentioned increase in appetite, and in addition, nausea, vomiting as a result of choline blocking activity, dryness of mucous membranes, eye disorders, blurred vision, etc. In case of repeated administration, as we mentioned, tachyphylaxis. All right, so thankfully we can now mention H1 antagonist drugs of the second generation, which is non-sedating. So we're talking about terfenadine, astemizole, loratadine, acrevastine, cetirizine, etc. Right? And we have the structure of loratadine here because we're going to be looking a little closer at it further on. All right, so we have another question. Identify the second generation anti-allergic drug from the list seen here. So we have 4 drugs. Tell me which one is a second generation anti-allergic drug. Well, if you said astemizole, then you are indeed correct. All right, so we are looking a little closer on terfenadine, and this is the structure. It is a selective, long-acting, 12 hours H1 antihistamine with little affinity for muscarinic, serotonergic, or adrenergic receptors. So that sounds good so far. The histamine receptor affinity of this compound is believed to be related primarily to the presence of the diphenyl methyl piperidine moiety, which is here. So we have our phenyl piperidine moiety here, methyl. The prolonged action results from very slow dissociation from these receptors, and the lack of anticholinergic, adrenergic, or serotonergic action appears to be linked to the presence of the N-phenylbutanol substituent. So on the other end, right? So we have a butanol here. In terms of the metabolism of terfenadine, it undergoes significant first-pass cytochrome P450 or CYP-based metabolism, with the predominant metabolite being fexofenadine, and you might be familiar with this, an active metabolite resulting from the methyl group oxidation. So this is the structure of terfenadine. This is the structure of Fexofenadine. The only difference, because we have a tert butyl here, the only difference here is that one of the carbons have been oxidized to a carboxylic acid. That is the only difference between terfenadine and fexofenadine. And so terfenadine is metabolized to fexofenadine. And fexofenadine is also active. All right, so as we mentioned, but just to give a little bit more detail, CYP enzyme is responsible for metabolism of, that is CYP 3A4 is responsible for metabolism of 60% of all drugs. It comprises approximately 28% of hepatic cytochrome P450. Right? So that's a good amount of hepatic cytochrome P450. It metabolizes terfenadine. So ingestion of grapefruit juice reduces expression of this enzyme, and it's inhibited by some regularly used drugs. So we have some issues with terfenadine. So even though it has all of that wonderful activity that we quoted earlier, when drugs that inhibit this transformation, that is the transformation from terfenadine to fexofenadine that we mentioned earlier. So drugs that inhibit the transformation, such as imidazole antifungals and macrolides, are used concurrently, terfenadine levels may rise to toxic levels, resulting in potentially fatal heart rhythm problems. Let me repeat that. So how terfenadine is metabolized to fexofenadine, right? So there are some drugs that inhibit that transformation, such as these antifungals and macrolides. When they're used concurrently or the same time as terfenadine. As a result, terfenadine levels rise or may rise to toxic levels, resulting in potentially fatal heart rhythm problems. The observation that fexofenadine displays anti-histamine activity comparable with that of terfenadine, but is less cardiotoxic, led to its development as an alternative to terfenadine for the relief of symptoms of seasonal allergies, right? So the fact that when terfenadine is metabolized, it produces fexofenadine, and if fexofenadine have comparable activity if fexofenadine has comparable activity to terfenadine, then why not use fexofenadine if it has less, if it's just as active or more active, whichever, and have less cardiotoxic activity? So these second generation antihistamines have high specificity and high affinity for H1 receptors, and one plus is that they are non-penetrable through blood-brain barrier in therapeutic doses, so therefore they have no sedative action. And they also have absence of blockade of other types of receptors. So cholinesterase receptors, we mentioned that. And it doesn't cause increase in appetite and body weight and all of these issues that we saw with our first generation drugs. All right, they also have long duration of action, so over 24 hours. And this one you can take one time for the day. Absence of tachyphylaxis, so they can be administered for a long time, up to a year. After withdrawal of the drugs, they have efficiency during the first week. What are some of the side effects? And we did mention some of them, which is why we said Fexofenadine was a better choice. But just to reinforce here that drugs are metabolized by CYP450 enzymes, terfenadine, etc. In patients with liver diseases, in case of higher daily doses with administration of drugs that are also metabolized by CYP450 enzyme, can cause ventricular tachycardia, which is heart rate over 100 beats per minute, pretty fast, right? So examples of these drugs that are that should not be administered along with these terfenadine, for example, we mentioned the macrolides and the antifungal drugs. So they shouldn't be administered along with terfenadine. Drugs are contraindicated during pregnancy and lactation. So let's look at the pharmacological characterization of antihistamine drugs of the third generation. So these drugs are pharmacologically active metabolites of antihistamine drugs of the second generation. And they have been created to eliminate cardiotoxicity and enhance the effect. So H1 antagonist drug of the third generation, Fexofenadine. No surprise there, right? So I'm sure you may have heard of Allegra or Telfast, which is the active there is Fexofenadine, and it's a third generation antihistamine. So we saw the structure already, so just to reinforce here that Fexofenadine is a primary oxidative metabolite of terfenadine. Terfenadine was developed during a search for a new butyrophenone antipsychotic drug. So a lot of our pharmaceuticals, the intended purpose wasn't necessarily what it turned out to be, but it was, however, useful for something else. Fexofenadine is indicated for the treatment of seasonal allergic rhinitis and chronic idiopathic urticaria, which is hives of unknown cause. It is rapidly absorbed after oral administration, producing peak serum concentration in about 2.5 hours. Fexofenadine is 60 to 70% plasma protein bound. Unlike its parent drug, only 5% of the total dose of fexofenadine is metabolized. Alright, so the remainder is actually excreted primarily in the urine. So the mean elimination half-life is about 14 hours. So the dosage form, tablets, oral disintegrating tablets, oral suspension, and the doses vary from 60 milligram twice daily or 180 milligram once daily in adults and children 12 or older. All right, so the next thing that we want to look at or want to tackle is a synthesis of fexofenadine. So don't be intimidated by this slide here, because I'm sure you're familiar with some of these reactions. So the starting materials for fexofenadine are piperidine 4-carboxylate ester, which is here, and 4-bromophenyl acetonitrile, which is here. Right, so following the first level, we see this, and I think it should jump out to you as a Grignard reagent, RMGBR. No? All right, well, it should, right? So our Grignard reagent reacts with the ester portion. So as we can see, our phenyl is now twice. So if we recall how our ester group is, it's our carbonyl and OET. So the first attack would result in a loss of the ethoxy portion, OET. And then the second attack would result in the formation of our hydroxyl here. Right? So that is how we end up with this intermediate. And for the second step, we have a substitution reaction where our nitrogen is nucleophilic, attacking this electrophilic center, which will result in the loss of our bromine or bromide. So our new bond is therefore formed between our nitrogen and our carbon here, as we see in, this intermediate. So substitution reaction there. And then the second step, is conversion of the acetal to the aldehyde, right? So it's a deprotection step essentially. So the acetal is converted to our aldehyde. That's the first step. For the conversion of 4-bromophenyl acetonitrile, the first step involves the reaction of a base, which is potassium terbutaoxide, attacking or pulling that both hydrogens from this position, resulting in a carbanion, which will then be nucleophilic and add our iodo and attack our iodomethane on the electrophilic carbon here, much similar to the reaction up here, and resulting in, that would happen twice, resulting in 2 methyl groups being added here. So essentially the nitrile group is now converted to a carboxylic acid in the presence of sodium hydroxide, and then the other step involves the formation of a carboxylate, because we have a base here that can pull this proton, and then we have elimination or loss of the bromide ion and substituting it with the lithium, and so the carbon here would actually be very nucleophilic, and to be able to attack our electrophilic carbon here of our carbonyl to form our hydroxyl group here, which is now fexofenadine. All right, so I don't expect that you will be very familiar with perhaps this reaction and this one, and even how they join together, but definitely the Grignard reaction, substitution reaction, the hydrolysis of the acetal to the aldehyde, and the base reaction to form a carbanion, and then reaction with iodomethane. So those reactions I expect that you would be very familiar with. All right, so looking at some other 3rd generation antihistamines which are also non-sedating, the first or the second one is desloratadine, which is the active metabolite of loratadine. And I did show you the image of loratadine at first. So here it is. And desloratadine is the active metabolite. So if we look on the structure, we can see that it was hydroxylated here, and that we have a loss of the ester group, right? So that would have happened in metabolism, and it gave us desloratadine, which is also active and a third generation antihistamine, trade name clarinexine here. And then another third generation non-sedating antihistamine is levocetirizine, which is the active metabolite of cetirizine. And essentially the only difference between both is the difference in the stereo center here of our chiral carbon. There is a difference in the stereochemistry associated with this chiral carbon. That's the only difference. As we can see, everything else is the same, but the idea here is that levocetirizine is a third generation, and it's a third generation antihistamine, and it is the active metabolite of cetirizine, as we have seen with loratadine and terfenadine. All right, so for the pharmacological characterization of antihistamine drugs of the third generation, well, they have three mechanisms of actions, and the one antihistamine, they cause blocking of the H1 histamine receptors. They're anti-allergic, and they also have an anti-inflammatory effect. The action begins in 15 to 30 minutes after the intake and lasts more than 24 hours. And they're also one a day, as with the second generation antihistamines. So thankfully they are not linked to cytochrome P450 system, and thus it does not overload hepatocytes in relation to detoxification function. They have no cardiotoxic action, which is great. These medicinal drugs are excreted by the liver and kidneys in mostly unchanged state, because we saw with fexofenadine it's like 5%. Owing to such peculiarities, can be taken concomitantly with other preparations, unlike the second generation drugs. The indications for use of second and third generation antihistamines: allergic rhinitis, allergic conjunctivitis, acute urticaria, which is the hives, atopic dermatitis, bronchial asthma, etc. And our final question is: in the synthesis of fexofenadine, identify at least 2 reaction types. So you can go back to that and see if you can identify at least 2 reaction types, 2 that you are familiar with. Alright, so that is basically the end of this presentation. If you made it to the end, thank you so much for watching, and see you next time.